Hello and welcome to our listeners from around the world. This is JAMA Network Open Conversations. I'm Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Baptiste about beta-Lactam inoculum effect in Methicillin-Susceptible Staphylococcus aureus infective endocarditis. Welcome. To begin, can you please introduce yourself?
Hello, thank you for having me. I'm very pleased to share this finding of this study. My name is Baptiste and I am an infectiologist in University Hospital of Henri Mondor near Paris.
So as an infectious diseases physician myself, I was really excited to read this paper, as the inoculum effect in the setting of Staph aureus bacteremia is something that we're always worried about, always concerned about. Can you give us a brief summary of what the inoculum effect is in this setting and the background of your study?
Yes, the inoculum effect is defined as an increase of MIC of an antibiotic observed when high inoculum is compared to a standard inoculum. So a high inoculum is approximately 10 to the power of 7 CFU by milliliter, and standard inoculum is approximately 10 to the power of 5 CFU by milliliter.
Great. And tell us a little bit about the background of this particular study.
In France, we usually used anti-staphylococcal penicillins in invasive Staphylococcus aureus infection before 2016. But between 2016 and 2018, there was a shortage of anti-staphylococcal penicillins, and we had to use cefazolin in this indication, in endocarditis too.
And what did you do in this study? Can you give us a brief overview?
So in this study, you focus on the impact of the inoculum effect of beta-lactams used in the treatment of infective endocarditis caused by Methicillin-Susceptible Staphylococcus aureus. We investigate the correlation between the presence of BLAZ, the gene which encodes beta-lactamase, the inoculum effect, and the mortality at 1 month of treatment.
Great. And what did you find?
So we focused on left side heart endocarditis. First, approximately 1/4 of patients died within the first month of treatment, and there was no difference in 1 month mortality between the group treated by cefazolin and the group treated by anti-staphylococcal penicillins. However, more than 1/4 of these bacterial strains were BLAZ negative, and these infections and infection associated with these strains had better prognosis with a mortality rate of only 12% at 1 month of treatment. In the group infected with BLAZ positive strain, the 1 month mortality of patients treated with beta-lactams to which the strain exhibited an inoculum effect was 40%, and it was only 20% in the group without inoculum effects.
And can you comment a bit more on the findings related to anti-staphylococcal penicillins and the inoculum effect? This isn't something that has necessarily been borne out in vitro data prior to this point.
Yes, the cefazolin inoculum effect is well described in the literature, but the oxacillin inoculum effect is not well described. For this article, we chose the definition of 4-fold increase of MIC to define the inoculum effect for cefazolin and for oxacillin.
And so, taking these findings in hand, what can we conclude, being cognizant of the limitations of the study, from this particular cohort?
Firstly, we did not observe a difference in efficacy between cefazolin and anti-staphylococcal penicillins. However, this retrospective study will need to be confirmed by a clinical trial. Secondly, we were surprised by the proportion of BLAZ negative strains. Approximately 1/4 of the episode can be treated by penicillin or amoxicillin, and this group had a better prognosis. Next, the inoculum effect appears to have a significant impact on therapeutic success in infection with high inoculum, such as endocarditis. This raises the question of the potential impact of this effect in other high inoculum infections, such as osteoarticular infections. And finally, how can we better treat infections caused by strains exhibiting an inoculum effect? Should combination therapy or BLAZ inhibitors, such as clavulanic acid, be used? This question remains open.
That's great. This is a really interesting study. And I wanted to mention there's an excellent accompanying invited commentary with this manuscript that highlights, I think, several important points. One, that most of the deaths that occurred in this cohort occurred early within the first 10 days, which perhaps suggests other underlying risk factors for mortality apart from the antibiotic employed. But also, I think, really interestingly, the authors of that commentary note that the proportion of Staph aureus strains in this study that produced beta-lactamases and demonstrated an inoculum effect is high, and perhaps higher compared to other studies, and brought up the question of whether this could reflect something about the geographic area and local epidemiology. And I wonder if you could speak more on this point.
Yes. For example, the strain without the BLAZ, there are actually two other actually described with strain. In USA, in one center, the rate of this strain rise 30%. And in Chinese, another article studied this strain. In this country, we rise approximately 10% of strain without BLAZ.
So perhaps suggesting something about the fact that local epidemiology or local geography may play a role in outcomes.
Yes, the distribution of Staphylococcus aureus is very local. And for example, in USA, there are more methicillin-resistant Staphylococcus aureus. So we must investigate the resistance to the methicillin, but also to the penicillin in our country.
That's great. And before we wrap up, are there any final thoughts regarding this topic or this study? Anything that we may have not covered already?
I want to thank every participant to the Chimère project on Rennes, Toulouse, and Paris.
Great. Thank you so much for speaking with me today about this very pertinent topic. I'm Dr. Angel Desai and have been speaking with Dr. Baptiste Jean about beta-Lactam inoculum effect in Methicillin-Susceptible Staphylococcus aureus infective endocarditis. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.